Hi, good morning, everybody. Welcome to this awareness session for sudden cardiac arrest, a panel discussion amongst colleagues for years. And if I may see the slide, please, I would like to introduce the moderator to the session. May I have the slide on the screen, please?
Dr. Suri, you're requested to share the screen.
Yeah, can you go on the slide? So, the moderator to the session, who's going to take the session forward, is Dr. Kawan Suri. He is a very old colleague with me. We have worked together in Escorts Heart Institute and Research Center. He's an intervention cardiologist with a lot of accolades to his professional career, and he did his DM from Skims Hospital, Jammu and Kashmir, and then received his fellowship in Society of Cardiovascular Angiography and Interventions. He also has received European Society of Cardiology Fellowship. He is an excellent intervention cardiologist. He started a lot of new procedures in Punjab, and he is doing excellent work. He was trained to be an electrophysiologist, but somewhere down the line, he became an intervention cardiologist. But he's developing his interest back into that job. It will be a good idea to have him both do interventions as well as EP, because EPs are always special. And he has a lot of he has a passion of writing, and he is a editor to 2-3 index journals. He's written a lot of articles. He regularly writes in the newspapers on social, academic, as well as research topics, and which are very well received by everybody. And so I hand over to Dr. Suri from here to take the session forward. Over to you, Dr. Suri, please. You have to unmute yourself, please.
Thanks, Dr. Vanita, for such an introduction. And I started, actually, as you said, as started working as an in the Department of Electrophysiology. But seeing Dr. Mathur and Dr. Bali, I thought that intervention, I should go on the intervention side. But again, getting back into your touch, I feel that I may add an electrophysiology as well. So thanks for such an humble introduction, and it's my honor to be part of this cardiac awareness program, especially on this World Heart Day, which is going to be on the 29th of this month only. And we felt that we are facing an unprecedented situation as of now because of COVID, and there are a lot of updates, the social media, the news channels involved in upgradation of the knowledge about the COVID. We thought that this is, and in the meantime, we got the news of one of the famous cricketers, Dean Jones, who had a sudden cardiac arrest, and he, despite the efforts, we were not able to save him, and he had suffered a sudden cardiac arrest. And this thing and the money news before this as well made us think about discussing this topic. This is one of the underrated, under-discussed, and under-mentioned topic, not only among the common masses, not only among the general public, but also among the medical fraternity. And many other times, as a professional, we feel that we don't discuss this entity with the patients and with the attendants as well. So what we look into the news, what we look into the media, is just the tip of an iceberg. When we see the celebrities like late APJ Abdul Kalam, the cricketers, the president of BCCI, Jagmohan Dalmia, and recently Dean Jones. So these are just the tip of an iceberg who had the same terminal event of the sudden cardiac death. But if we see to the burden of the sudden cardiac arrests in general population worldwide, in about 90 seconds to 2 minutes, one sudden cardiac arrest occurs. So we can see the burden of the disease is so much, but still we are not aware about it. And to discuss this topic so minutely, I felt the need of the choicest faculty members. And when I opened my eyes, I felt that there are the best I could get, not only from the North India, but from the country as well as of the persons of an international repute. The three names which came to my mind is Dr. H.K. Bali sir, the Dr. Mathur, and Dr. Vanitha. And I have involved both the interventionists as well as the electrophysiologists in this discussion, because this is not an entity limited to the interventional cardiologist. This is not an entity limited to the preventive cardiologist who treats, who is a non-interventionist cardiologist. And it is not the priority or the field limited to the electrophysiologists. So we have to come in unison together, and I thought we should be together on one single platform so that the message goes clear and we are able to make people aware about this entity. And I feel if we are able to save one life just because of this, our association of getting this platform together, I feel the job of our work for a week or so, what we have been doing for this platform, the job is going to be done. So we have the three experts, and just before we go into the discussion, I need to introduce. I don't feel their stature is beyond my imagination, and I'm telling it from the core of my heart. So I feel just a formal introduction of these three masters, but if we go deeper into the introduction, I feel they are beyond my imaginations. So we have Dr. H.K. Bali sir. He's a renowned figure not only in Punjab but on the national all over India. He has done about 15,000 angioplasties, more than 150 plus carotid stentings. He's one of the first operators of carotid stentings, and he is the first person to do structural heart disease in the form of TAVI in Punjab. So he has more than 75 papers in international and national journals, and he has trained more than 50 DM students. And in fact, I tell you that even after the DM, he is always helpful, and he is instrumental in sharpening the skills of the interventional cardiologists. So I welcome Dr. Bali sir on this platform. I thank you from the core of my heart for taking time and being here. We have Dr. Atul Mathur, a very renowned cardiologist, interventional cardiologist, and he's working as a director in interventional cardiology at Fortis Hospital, New Delhi. He's president of Indian Council for Cardiac Interventions and Cardiovascular Therapeutics. And since I feel the time I was there in Escorts 2008 or 9, Dr. Mathur sir started this CVT program, and every year he's been performing, he's been conducting the workshops and the cardiovascular therapeutics CMEs every year. So every year he's adding new strategies, the new interventions and new procedures in that. So he's the first Indian doctor to obtain a US patent for a medical device which is used in performing the carotid stenting. He has over 100 research publications, and many procedures he has done for the first time. They are being now used, or the technique is being used by the young cardiologists like us, and it's now established everywhere in the country. So he has a significant contribution from, and he has his experience. He has gained his experience from the All India Institute of Medical Sciences and University of Alabama at Birmingham. So I welcome Sir Dr. Mathur sir for taking time and being here. And we have one of the renowned electrophysiologists, I tell you, but she's doing an intervention also. She's the fellow of the Royal College of Physicians and is also an MRCP examiner. So if any of us is going to go for an MRCP exam, she is going to ask the questions out there. So she is pioneer in the country for 3D mapping, leadless pacemaker, cardiac resynchronization therapy, his bundle, left bundle branch spacing. So whatever new comes in the kitty of electrophysiology, she's always instrumental in trying and doing it. She has more than 3,000 radiofrequency ablations, 3,000 plus pacemaker implantations, 2,000 plus BIV. So everything is in thousands. So you can think about how much experience Dr. Vanitha has. She is currently the secretary of Indian Heart Rhythm Society. She is president IMA New Delhi branch and vice president Indian Society of Electrocardiography. So I thank Dr. Vanitha also, and in fact it is her birthday also today, so we wish her happy birthday as well on the same day. So, so in the meantime, while we'll be discussing, so I will stop the sharing of the screen and we will be here. So in the meantime, I request my friends and colleagues who are watching this program to put their queries so that once we are finishing or once we have finished this discussion, we are able to get the maximum benefit from these experienced faculty what we have. So Dr. Bali sir, we want to see your face here. So we want your video on and so that we can. So good morning, Dr. Bali sir.
I thought we had a pretty Dr. Vanita Arora, and she should hog all the limelight today because of her birthday and expertise. So let's start with Dr.
Yeah, but every face is pretty face, I feel. For me, Dr. Bali, Dr. Mathur, and the people who are watching, they are all pretty faces. So, Dr. Bali sir, once we are talking about the sudden cardiac arrest, we read in the newspapers the headlines, the young people, the old people, they are getting the sudden cardiac arrest. Can you throw some light upon what actually is sudden cardiac arrest and how is it different from the heart attack, what we call, or is it the same as we call the heart attack patients?
I think it has brought the focus back Dean John's death. And one day earlier he was playing. In fact, in the morning he had a breakfast. And then suddenly he collapsed, and despite efforts, he could not be saved. Sometime back, you mentioned about Jagmohan Dalmia, and sometime back, Rima Lagu, a famous Indian actress, had a very young age. So what we are seeing is that many people make their exit suddenly. In fact, this word itself is a paradox. When we talk of sudden cardiac death, we are talking about death on one side, and the other side we are talking of survivors of sudden cardiac death. But this could be not more important to discuss this topic than sudden cardiac death, because people who have sudden cardiac death, which is an arrhythmic death, that without any symptoms, within about half an hour or so, patient collapses and he is pulseless, BP-less, and that is what we call a sudden cardiac death. Most likely, most probably, it is an arrhythmic death, and there are a number of reasons why a person could get a sudden cardiac death because of arrhythmia. Coronary artery disease being one of them. I would not say heart attack, because coronary artery disease is obviously one of the very important reasons for sudden cardiac death. But in here, the patient is actually dying before the myocardial infarction is occurring. There is an arrhythmia because of a coronary occlusion and a primary ventricular arrhythmia. And if you do that of this patient, you would not have time for myocardium to develop infarction. So there are a number of reasons why sudden cardiac death is occurring. And I would not say that it is increasing, because previously probably people were not aware of this entity as much as they are today. They would previously say that the patient died of a sudden massive heart attack, which was not true. So we see young people and CEOs of the companies dying in sleep, or even just after. I had a neurosurgeon, a friend of mine from neurosurgery department, PGI, who had gone to attend a conference in Bangalore, and after dinner he had a SCD. So this is a very common problem, and what is important to discuss it is that we know that there are predictors where we can talk about this sudden cardiac death. We know how it manifests. We know we have means today to salvage these people if timely help is available. That is why we go on to train our doctors, paramedicals, general public also, because this may happen on the roadside, it may happen on a bus stand, it may happen on a railway station. The person standing next to you in a queue may have a sudden cardiac death. So we intend to reach to a stage where sudden cardiac death is recognized immediately and there is availability of help at hand, and we would be able to save them. So what I would say is we need to focus on this entity of exit for many people, and it's different from heart attack in the sense that it's an arrhythmic death, and the coronary artery disease is one of the reasons. There could be myocardial reasons. We will talk about that. What are the cardiomyopathies which cause the word? What channelopathies cause the word? There are enormous number of reasons. Sudden cardiac is a arrhythmic death occurring within half an hour of onset of symptoms.
So we have the sudden cardiac arrest is occurring within the half an hour, and if the person is not alive for the, if not seen alive for the 24 hours, we call it a sudden cardiac arrest. And as per Dr. Bali has said, the heart attack is different from the sudden cardiac arrest. It may be the heart attack may be one of the causes of the sudden cardiac arrest, but the two entities are totally different, and the management is different of the two as well. So Dr. Mathur sir, as Dr. Bali sir has already talked about the coronary artery disease as one of the causes of the sudden cardiac arrest or the symptoms or signs of sudden cardiac arrest. What are the other causes we should look for in the patients or in the people who have a sudden cardiac arrest, apart from the coronary artery disease?
So, thank you, Kawan, and thank you everybody who is organized to invite us for this discussion. First, I think it would be very interesting to understand the structure of the heart for the general people. So the heart is a very muscular organ. It is made of 4 chambers, like 4 rooms in this house. 2 of these chambers are the pumping chambers. They are made of muscle and they're called the ventricles. The left ventricle is pumping blood into the fresh blood with oxygen into the rest of the body. And the right ventricle is getting blood back from the whole body without the oxygen which has been used and which has other impurities. So to keep pumping, and for the muscles to keep working constantly, there are 2-3 important things in the heart. One is the coronary arteries. These are the pipes. These are the main 3 pipes which are supplying oxygen and blood to the heart. And if there is an acute clot formation in these coronary arteries, then this will lead to electrical changes, lack of oxygen, lack of blood supply into certain area of the heart where the blood was going. And that can lead to irregular heartbeat setting up into the heart muscle. So when the heart muscle starts beating very fast and irregularly and without a synchronous beat, so that is what usually we call as ventricular tachycardia and ventricular fibrillation when the heart stops suddenly because the electrical seizure has taken place. So that is cardiac arrest. So you have understood the cardiac heart attack is when the artery is blocked and it damages the heart muscle. And in the sequence of events, one of the complications which can happen is a cardiac arrest. But cardiac arrest due to ventricular tachycardia, ventricular fibrillation, or sometimes due to sudden slowing down and stopping of the heartbeat can also occur due to other reasons than heart attack. So those other reasons could include if the patient has a primary disease of the heart muscle. So this could be an acute problem like a myocarditis where a viral infection or some other kind of infection happens in the heart muscle. Or there could be a chronic condition the patient is got like hypertrophy of the heart muscle or infiltration of the heart muscle with some certain materials. So these can also be triggers for causing the electrical sparking in the heart muscle. And this electrical sparking can lead to sudden heart arrest. So in routine evaluation, when the patient goes for a general checkup, the doctors usually look for certain things in the heart also, although you may or may not realize by doing the echocardiograms and by doing the electrocardiograms. And number of these conditions can be picked by routine basic tests. And once you know that this person is at a risk of having cardiac arrest, either he has heart blockages or he has these diseases of the heart muscle, or certain other situations where you have a brain stroke and you can trigger a irregularity or stopping of heartbeat. So these things should be screened for wherever you can prevent. Then there are certain methods. Dr. Vanita is an expert. She will take us further when more questions come.
Thank you, Dr. Mathur. So, thank you, sir. So we have the coronary artery disease, the blockage of, as Dr. Mathur has readily explained, and we have non-coronary reasons for the sudden cardiac arrest, like the hypertrophic cardiomyopathy, the various syndromes and various channelopathies. So, Dr. Vanita, when we are talking about the cause, the sudden cardiac arrest is one of the entities where the cause and the mechanism is different. The cause is the blockage and the mechanism is the arrhythmias. So how you are going to tell us about the immediate cause of sudden cardiac arrest, the role of various medications which are precipitating the sudden cardiac arrest in particular group of patients, and some light on the VT, as Dr. Mathur sir has already talked about the VT. What is VT or VF or pulse electrical activity, and what are the prognosis of these in patients of sudden cardiac arrests?
You need to unmute yourself, Anita.
Thank you so much, Dr. Mathur. Thank you, Dr.
Again, Dr.
Suri.
Mathur. Again, Dr. Vanita, Dr. Mathur has helped you.
Yeah, he always is a savior. I agree. That's why I admire him so much. Your question is really widespread, so I'll just try to answer it one at a time. And please, Dr. Mathur and Dr. Bali, wherever you can, please pitch in case I'm missing something. So you want to know first of all, you said what is the cause of arrhythmias that happens? Why does sudden cardiac arrest happen? Sudden cardiac arrest happens when there is a cessation of blood supply to brain, especially, and it is because the heart stops. Why does the heart stop? Because of either asystole, which means it just stops to beat, or most important cause is a arrhythmia, the faster heartbeat coming from the lower chamber of the heart. Now, this is an electrical malfunction. If I have to explain it in very simple language, what I would say is that if there are two electrical wires lying, two opposite electrical wires lying close to each other, there will be sparks coming out from there. So it is similar. Similar example happening inside the heart, where there are sparks happening from the electrical system short circuiting, which happens inside the heart, and it causes a very fast heartbeat, and the blood pressure collapses because the heart is not able to cope up with such a faster heartbeat. Now, the prognosis, as Dr. Suri asked about this situation, the survival rate of out-of-hospital cardiac arrest is less than 2%, which means if 100 patients have out-of-hospital cardiac arrest, 2% of these people will survive. And if we look at the data from United States of America, this severe percentage is hardly 5%. So in a country which has probably the most quick response to the emergency, there also the survival rate is hardly 5% in there. So 95% of these patients will die. Hardly 2 to 5% survive. This is how the prognosis goes by. The other part of Dr. Suri's question was, are there any drugs which can cause sudden cardiac arrest? There is a long list of drugs which can cause it, and the major reason for them is they cause a disturbance in the ECG. There is a segment in the ECG called QT interval. That QT interval is prolonged. It gets increased by the usage of these drugs, and knowingly or unknowingly we take those drugs, and the QT becomes prolonged, and it can cause this electrical short circuiting in the heart. The routinely used drugs, which I can name a few, are some antibiotics. Hence, we should never take antibiotics without the consultation from the doctor. Certain anti-allergic medications that we take, antihistaminics basically. There are some antipsychotic drugs which can cause this, and then there are some drugs used for seizures given by the neurologist, which can cause the prolongation of the QT interval, which can lead on to this very potentially lethal the rhythm coming from the lower chamber of the heart. If anything else needs to be added, Dr. Bali, Dr. Mathur, Dr. Pawan, please go ahead and do that.
Thank you, Dr. Vanita. Dr. Bali is saying something. Sir, mute yourself.
Sir, unmute. Sir.
Sorry. I was only saying that, there are a number of drugs which cause a QT prolongation, but the propensity for them to cause is low. So more important would be cardiomyopathies. There are channelopathies. There are genetic disorders which I think you are going to come to, where you may have a QT prolongation, and those are more likely to cause problem, and cardiomyopathy. In cardiomyopathies, hypertrophic cardiomyopathy is extremely important. we need to recognize it because of two facts. One is that it's genetic and it is prevalent in patients otherwise may be entirely asymptomatic. And there is a proportion of young adults who may be more prone to have a certain cardiac death because of hypertrophic cardiomyopathy while playing or undergoing sports activity or exerting too much. Therefore, we need to recognize that entity and investigate that further, do a family evaluation to see. So what I would say is that there is a large segment of patients who may be, there's a minuscule but a significant percentage of people in the general population who may be otherwise asymptomatic but suffering from cardiomyopathy. I remember one of the cricketer in UK who was a test cricketer and had played about 15 tests, and he was recognized to have an arrhythmic right ventricular dysplasia, and he had to leave the cricket and had a ventricular defibrillator implanted, ICD implanted, and now he's a selector. So what we need to recognize is that there are a few cardiomyopathies which are prevalent in young people, and we need to recognize them early by both a clinical evaluation and ECG and echocardiography, and sometimes more extensive evaluation by an MRI to diagnose these cardiomyopathies and therefore take precautions to the extent that they do not have a certain cardiac death. So I would say that coronary artery disease is one, number two cardiomyopathies, and then channelopathies would be three, and four would be drugs, because drugs, although there are a number of drugs which cause QT prolongation and a type of ventricular, what we call as a polymorphic ventricular tachycardia, but the percentage of those patients would be a little less, and these are over the counter available drugs, and we shouldn't be giving a message that or other blockers or antihistaminics would very significantly cause this QT prolongation. I would say this is one of the rare side effects of the drug, and particularly more common in those people who have an underlying underlying heart disease, maybe cardiomyopathy, left ventricular dysfunction, or coronary artery disease. But otherwise, the incidence of these drugs causing is a little low. So I would put it that way, but my opinion, perspective to say that we shouldn't be scaring people about that.
No, that is absolutely right, sir. I admire that. That is really very nicely put in things. My idea to put in the statement which I said was because so the congenital heart disease which causes long QT goes unrecognized, especially in children, because there is no way that our children are getting investigated or getting at least an ECG done during their childhood. And I have very recently come across at least 5-6 such patients whereby they've had no checkup. Probably what I'm trying to say is that these drugs should not be unjudiciously used. And there should be some criteria or some importance given to a child, at least in the getting investigated or getting an ECG done or seen by a pediatrician. Because I have seen some cases, that is why it was on the back of my mind, and that is why I spoke it so strongly about these drugs.
I think just taking it a little further, you have children who may be put on anti-epileptic for a long period of time.
Correct.
Patients have a seizure-like presentation, and he goes to the neurologist, no ECG is done, and they have for years to take anti-epileptics. So I think you have brought up this entity very nicely, that children need also to be investigated for a prolonged QT, which may be genetic syndrome.
And a more recent comparison is in the drugs which are used in COVID management, hydroxychloroquine and azithromycin. So much has been discussed about it, and there have been some negative reports on combining these two. Again, arrhythmia and sudden death is probably the mechanism over there.
Right, sir. Absolutely.
Yeah, this is the reason I just came to the drugs. I feel the combination of drugs should be, kept into consideration. As Dr. Bali has said, that the patient on anti-epileptic therapy or the patient on antipsychotic medications, once they take these quinolones or these anti-allergic medications of their own, the prognosis is going to be different. The combination of medications, is a different scenario. Taking a single medication is a different scenario. So I feel the combination of medications or what the US people are doing, the over-the-counter medications should not be taken without the consultation of the doctor. So this is the message I feel what all the three experts have given to me and as well as to the viewers. So Dr. Bali sir, we talk about the sudden cardiac arrest, and everybody, each one of us know about what actually the sudden is. So are there, as we believe in, we are the Indians and we believe in sixth sense, or we believe in intuition, or we believe in, whatever, we can forecast the things. Like the vaccine is going to come in August 15. So we can forecast the things without going into the logistics most of the times, especially when we are talking about the social media things nowadays. So are there any warning signs for the patients who have a certain cardiac arrest, or it happens out of nothing and the person comes and goes, or there are any warning signs we should look for, the family member should look for those warning signs?
I think if we look at symptoms, it is quite likely, because this is, as Dr. Vanitha nicely said, more commonly because of ventricular tachycardia, fibrillation, which Dr. Atul explained very nicely, that there is a rapid irregularity of the lower chamber ventricle. And because these ventricular arrhythmias may be preceded by short runs of ventricular arrhythmias. So there may be patients who may have for weeks or days, they may have something what we call as a pre-syncope, a feeling of a lightheadedness or just collapsing without symptoms. What we call as a cardiac syncope, because we need to differentiate a cardiac syncope from a neurological event like an epileptic seizure. So there may be patients who may have symptoms that suddenly they lose consciousness and there is no aura, there is no feeling to the patient that something is going to happen. It just drops, and there may be little sweating and nothing else. And after a few seconds, the patient regains his consciousness and is fully aware of his surrounding. There is no post-ictal phenomena, what we call as any neurological disturbance or headache or any feeling of vomiting after that, or loss of awareness of the surrounding. So that is important to know, that if you have a person who has dropped he loses consciousness and feel lightheadedness, we need to evaluate these people more aggressively. To look for, do an clinical evaluation, an ECG on these patients, an echocardiography, and a Holter monitoring these people. And if we are still considering them, then we might go for a prolonged monitoring like a ELR, external loop recorder, where we can do recording for 5 days, 7 days, or even longer, to find out these episodes may be very rare. It may occur once in a month and patient may have actually forgotten. So there are quite number of these patients who may have preceding symptoms which may indicate a short episodes of loss of consciousness. In history, a doctor can understand that it is because of a cardiac event and evaluate them and pick up those patients and prevent a sudden cardiac death. That is one. Second, we need to find out a family history. There may be families where there may be a history of strong sudden cardiac death in the family, and at a young age. Maybe a father or maybe a sibling or somebody. So we need to evaluate those people to find out that they may not have a hereditary cardiomyopathy, or they may not have congenital QT syndrome. So that is the other thing. If you get a strong family history in a person, that is the second thing which you need to look. I personally believe that everybody who has to undergo endurance training, or who has to be a sports person, an outdoor sports person, should have a detailed evaluation done earlier to find out that he's not suffering from some such condition. We have, international sports people having a sudden cardiac death in a football match and other places. So therefore, we need to have all those people who are into endurance training should have an evaluation of these people. So I see a lot all around. So therefore, we should be going further that, there may be history, there may be a clinical evaluation, and ECG echocardiography. Yes, you are right that many of these patients who eventually suffer from sudden cardiac death may give you some indication that such a event is likely to come.
Yeah, so the important thing or important message here is to differentiate between the cardiac cause of the cardiac arrest or the cardiac syncope and the neurosyncope, and most of the times it is very difficult for the clinician to differentiate between the two. But there are some soft pointers, as Dr. Bali sir has already talked about, like transient loss of consciousness, sudden quick regainness of the consciousness, and then no associated aura or incontinence of urine or tongue bite. They are the soft pointers which can go towards the cardiac syncope. So more importantly is that we should believe on our sixth sense, and this is what experience is all about. People call it a sixth sense, people call it an intuition. It is all an experience, what Dr. Bali has already discussed about. So Dr. Mathur sir, we have seen the different age groups, almost all the age groups, they are involved in the sudden cardiac arrest. We have the extremes of age, the sudden infant death syndromes, especially in the first 6 months of the birth. The baby is getting the sudden cardiac arrests, and the extremes of age are more elderly getting the sudden cardiac arrest. Is there any gender bias for the sudden cardiac arrest? Are women less prone to have these, or it's a generalized statement?
Well, it has always been initially said that women are less prone to heart diseases. This was a belief which people have had for a long period of time, for decades.
Dr.
Slowly and slowly. Oh, sorry. Is the audio not clear?
No, audio is clear, but Dr. Vanita is very happy because she feels she is safe from sudden cardiac arrest.
I'm not happy. I'm actually why I'm laughing is because this statement is no longer true. This is a myth.
Yes. Let me come and complete my
please go ahead, Dr. Mathur.
Yeah. So this was probably due to various reasons why this belief was there. Probably women were not well evaluated and they were not coming forward for treatment. As more and more literature has come into publication, and more women are coming forward and getting treated and checked, just like men. They are shoulder to shoulder with men now in most of the fields. So it has been realized that they also are at equal risk as men have. There may be certain diseases which are slightly more prevalent in women, and there will be certain diseases which will be more prevalent in men. So, and continuing with your previous question, all said and done, whatever we are talking about screening of and indicators of sudden cardiac arrest, the most common cause for cardiac arrest still continues to be coronary artery blockages. And if you have to look for predictors of sudden cardiac arrest, you have to look for predictors of heart attacks, angina, and other indicators, because ultimately these are the people who are also at a risk of cardiac arrest. So women are neck to neck with men in the incidence of coronary artery disease. Age has an important implication on the incidence of sudden death in the form of diseases. Some diseases like congenital diseases, which are present since birth, are more likely to get these problems earlier in life. Diseases like infection, viral infections, myocarditis, and other problems are likely to happen earlier in life, and they can happen at later in life also, but they will dominate the sudden deaths which happen earlier in life. Whereas coronary artery blockages, atherosclerotic obstructive disease of the heart arteries, usually gets to show its increasing incidence after the third, fourth, fifth decades, and more in fifth, sixth, seventh decades. So if you look at the age spread, artery blockages will be more prevalently seen in later ages. Heart muscle disease, infection of the heart muscle, congenital problems of the arrhythmia causing diseases of the heart will be seen in younger age, including children who can sometimes be born with very complex heart problems. So this is a generalistic view about what I'm saying. Back to you.
Thank you, Dr. Mathur, sir. So, as has been discussed, that there is no gender bias as of now, and it should not be there. But I feel still the females are much stronger species than the men are. So, Dr. Vanita, we are discussing so much about the sudden cardiac arrest. I have a simple question: is it worth discussing it? Looking into the burden of this sudden cardiac arrest in the Indian scenario, or the prevalence of the disease. If the prevalence of the disease is very high, then it is worth discussing it. Have you any data from the Indian population about that?
Well, you started asking this question, Dr. Suri, saying, is it worth discussing it? I would like to emphasize on that line which you said. Is it worth discussing life?
No, I just wanted to know about the proportion or the burden of the certain cardiac arrest.
Pawan, you're not supposed to reply. It is her birthday today. So.
I'm just replying,
Sir, actually, he is not even replying. Pawan sir is actually dodging the question. I asked him a simple question: is it worth discussing life? Knowing the prevalence of life.
Yeah, I feel it is worth discussing it because, among our medical fraternity also, and if we talk about the doctor patients also in the OPD, we don't discuss. I'm giving my own experience. We don't discuss about this entity much with the patients, irrespective of the low ejection fraction, irrespective of the high probability of having a certain cardiac arrest in the vulnerable group of patients. So that's why I asked you that should we discuss, is the proportion or is the burden of the disease so high that we should discuss this entity with every patient, and should the general public be aware about it? So that's why I asked about it. Is it worth discussing it?
So I will answer this question giving a scenario. Because truly speaking, we do not have any Indian data to tell us what is the prevalence of sudden cardiac arrest. We do not have this Indian data. We have data from US, from Europe. Their genetic profile, their body type is different from Indians. But I can just give a wide spectrum view of what we are dealing with. We are the diabetic capital of the world. We know that. Because of diabetes being a very strong, I should say, causative factor for coronary artery disease. The coronary artery disease has become almost prevalent all over the country. And it's no more south more than north or anything. It is like everybody has developed coronary artery disease. So diabetic capital, coronary artery disease widespread, and the most important cause of sudden cardiac death being coronary artery disease. So the correlation is possible. This is just a mathematical correlation. 2 + 2 is 4. In case we are having high incidence of diabetes, in case we are having high incidence of coronary artery disease, we have to have high incidence of sudden cardiac death. And the prevalence is more high of sudden cardiac death because the way we treat coronary artery disease, we are focusing on giving symptomatic benefit to the patient. We treat most of the times once you have coronary artery disease, you have it for life. You cannot get free from it. You cannot get away from it. All you are doing is treating the symptoms, whether it is in form of heart attack, angina, or dyspnea. You are just treating the symptoms. You are not making the patient free of coronary artery disease. Hence, there are some consequences to coronary artery disease which are associated with the ill effects of coronary artery disease, which we do not discuss. That's what Dr. Suri has just said, that we do not discuss neither in the OPD nor in the inpatients nor in our clinics. We do not discuss it. And that is why it gives me a lot of pleasure to be sitting amongst 3 intervention cardiologists and insisting on the fact that the prevalence of this disease has to be considered in relation to diabetes and coronary artery disease. And we need to know that sudden cardiac death incidence is much higher than what we believe. And as intervention cardiologists, you 3 should take it forward to, to discuss it more in the forum and to lay the emphasis that doing angioplasty, doing surgery to patients of heart attack is just not enough. Maybe something more needs to be done. Have I answered your question, Dr. Suri? Over to you.
I think I will take up that point a little bit further.
Yes, sir.
Please. When we talk of US or Europe and the data of sudden cardiac death in coronary artery disease, we are talking of a situation where a large majority of people there have a timely intervention for primary angioplasty and stenting. In India, if we leave the large cities, metropolitan cities or type B cities, most of semi-urban and rural India do not have facilities for a primary angioplasty. and many patients do not even get a thrombolytic treatment. So even in heart attack patients, they either present late or they have a delayed intervention, leaving behind a residual left ventricular dysfunction, which over a period of time would be a nidus for a sudden cardiac death. So I actually believe, even if the data is not present in India, that a large number of patients, more patients, and angioplasty stenting is not good enough. We need to find out how much is the residual ischemia. We need to take care of the left ventricular dysfunction. And if the left ventricular dysfunction is, we will come to that at less than 30%. And even if the patient is asymptomatic, 6 weeks post angioplasty, primary angioplasty, or an MI, then we are not likely to get more improvement in the left ventricular function. And this is one of the most important factor which will be responsible for sudden cardiac death. No other indicator, even class 1 symptomatic coronary artery disease, even if you have taken care of all ischemic arteries, it itself is a nidus for a sudden cardiac death. And these are the candidates we need aggressively to follow up. So I believe that as compared to Europe and US or other countries, developed countries, we are missing on this aspect of management. We talk about rehabilitation, we talk about physical rehabilitation, psychological rehabilitation, but we do not talk about long-term consequences of coronary artery disease. Although beta blockers, which we regularly use in these people, have been shown to decrease the incidence of sudden cardiac death, but it doesn't negate it. So these are the candidates which we need to identify and follow very closely, prime their families and the patients that they need something more to be done to prevent a sudden cardiac death. So 2 points. One, we need to spread the message around that in patients who had MI need a primary angioplasty or thrombolytic treatment well within time. 60 minutes after onset of MI as far as thrombolytic is concerned, 90 minutes are as close to as possible after an angioplasty. And having done that, subsequently we need to follow them for prevalence of risk for sudden cardiac death.
So, Pawan, you have noticed that Dr. Bali has been a professor in PGI. He's fond of giving long lectures. So
yeah, I teach my I teach my students about Nietzsche. Nietzsche once said that I want to say in a sentence, in a paragraph, what people don't say in a chapter or sometime not in a lifetime.
Correct. I'm just making it light, and let's not get very serious. Your points are very well explained. I know that.
But he explains very well. He really does a good job in explaining. I admire that. Dr. Suri, you have to unmute yourself, please.
Dr. Mathur, sir, there is, if we have a sudden cardiac arrest in a family, how prone are the family members to have that sudden cardiac arrest, especially if the patient or if the person is having a younger age, about a second or a third decade, and he has a sudden cardiac arrest. So what are the various risk factors the family should be thinking about, and how prone are those family members, the siblings like brothers and sisters, prone to have these sudden cardiac arrest? So unmute, please.
Yeah. So if we are talking about the second and third decades, the more likely causes of sudden death in this age group will be heart muscle diseases, right? Or infection of the heart muscle, or some genetically inherited disorders. So if you look at the heart muscle disorders, the cardiomyopathies, the commonest one which comes to your mind will be hypertrophic cardiomyopathy, as earlier our experts have also mentioned that. And this has a tendency to be inherited in siblings also. So hypertrophic cardiomyopathy is a disease where the walls of the heart muscles, of ventricles, so these walls, ventricular walls, are thick. The muscle, there is extra muscle which is formed since birth, and it is very unstable and electrically very fragile. And hence, there is an increased risk of electrical sparking in these heart ventricles and sudden death caused in these people. So if you have a history of a young sudden death, you should always, even if you have not been able to evaluate this patient, you should always suspect certain diseases of the heart muscle. You should call all the siblings, the parents, to do an echocardiography and ECG to screen whether these people also have inherited something similar to that. So I'm keeping myself confined to your question. Of course, if you go into a higher age groups, again, then the commonest causes are heart blockages. And heart blockages can also be inherited, and they have a strong tendency that they can run in families. So maybe the person was a known heart patient, or he was not a known heart patient but has a sudden heart attack and has a cardiac arrest due to that. Then also in that age group, the family members should be screened for presence of heart blockages, atherosclerotic disease in those people. Back to you.
Thank you, Dr. Mathur. So we should keep or screen the family if the person is having an hypertrophic cardiomyopathy. There is a higher tendency to have that trait in the family members as well. So we should screen the brothers and sisters and should treat them accordingly. So Dr. Bali sir, apart from the hypertrophic cardiomyopathy, are there other reasons or causes of the certain cardiac arrest in the young people, especially second or third decade, and how far are we helpful in doing the genetic testing in those patients?
I think Dr. Vanitha should be taking up this point, but Dr. Mathur mentioned about hypertrophic cardiomyopathy. We need to identify those people amongst those who have hypertrophic cardiomyopathy who are at a high risk of getting sudden cardiac death, and I'm sure Dr. Vanitha would mention those. Arrhythmogenic right ventricular dysplasia is another condition which we are recognizing more, and a patient may be entirely asymptomatic otherwise, and we may diagnose in echocardiography. We have a very classical ECG findings, which we may suspect on arrhythmogenic right ventricular dysplasia, what we call as ARVD, and we can diagnose that definitely by MRI. So they have cardiac MRI. So therefore, that is one condition which we need to find out. There are other cardiomyopathies, and in hypertrophic cardiomyopathy, there are a number of atypical presentation, which may not be classical look on echocardiography. We may not be able to diagnose hypertrophic cardiomyopathy, but we may have to do an MRI or more evaluation to diagnose these patients, especially if there is a family history of sudden cardiac death. So other are the channelopathies, which Dr. Vanitha would take up, that we have genetic disorders of conduction system, cellular conduction abnormalities, which we label as a QT prolongation. These are also genetic. So there are a number of other conditions which can be present in young people, which predispose them to hypertrophic cardiomyopathy. Dr. Vanitha, please.
Thank you so much, Dr. Bali. Dr. Suri, your question was very interesting about family history and screening of in children. I want to ask, if you give me the liberty, then I want to ask you this question. Telling you the scenario that in my clinic, I see that it is very challenging for me to let people be convinced about getting their children, their siblings screened in case they have been diagnosed either with hypertrophic cardiomyopathy or ARVD, as you said, sir, arrhythmogenic right ventricular dysplasia, or any condition which can be familial condition and may run in families. It is an impossible task in India. Since this is a public session, it is an awareness session. I want tips from you three. Have you found this a challenging task in your clinical practice? Because you people see much more patients than what I do. And have you had the challenge in convincing the family? If the father has a problem, I tell him, get your son, get your daughter screened for this, get an echo done, get an ECG done. There is a big scare on their faces. I don't know how to come out of it. I don't know how to convince them. So help me here, please. Then I will go back to the question that Dr. Suri and Dr. Bali have asked me. And this is a question to all three of you, please. Yes, Dr.
Okay,
Suri.
I will start. See, Dr. Vanitha, whenever the person is in a comfort zone, he doesn't like the change. So same happens with the health also. Once the family member is diagnosed or he has had a certain cardiac arrest, there are some families where you can convince them, you can tell them the importance and the importance of the screening, and they can comply with you. And there are some people who may not, who may go to the Google and then start searching here and there, And as Dr. Bali had a week ago written an article, I feel, on the Google Doctors only. So it was a very interesting write-up that way. So there are 5 different fingers in the hand, and all fingers are not same. So similarly, all patients, all attendants are not same. Some you may be able to convince easily. In some people, you may have to use some difficult language to get them convinced, and some may not get it. So it's a matter of their choice whether they want to get it or not. But it is our duty to make them convinced, to inform them that this is the entity and you should get yourself screened. Dr. Bali, sir.
Sir, unmute yourself.
Very and evaluating an unit spend. Here I use Google in a hospital. What I do is I tell the patient that the patient has got hypertrophic cardiomyopathy and tell him that it's a genetic disorder and tell him that it's going to run in family and tell him that this can cause a sudden cardiac death, and then advise the person to go on Google and read about hypertrophic cardiomyopathy and sudden cardiac death after having primed him. So once I have given him the lead, what to look for, then next time when he comes back, he's more amenable to suggestion and advice about screening of the family. So Google can be used both ways. And I use in this particular patient where I find I'm advising a rare treatment modality or say CRT or an ICD or something like that. I try and give my knowledge, what I understand about it, have a prolonged discussion with the patient, and then tell him to go to Google and come back with his questions. So that has helped me in convincing more people to have a family screening of those people who have been diagnosed with hypertrophic cardiomyopathy. Or where Mathur may add more on that.
Dr. Atul, sir.
Sir, unmute
Please
yourself.
unmute.
This availability of so much information online is both a bane as well as a boon. And number of times in my outpatient, when there are a lot of patients who have a lot of questions and some very basic questions, and we would like to actually sit down and talk to them more and more. Unfortunately, when you have so many other patients waiting, you're not able to give them enough time. So I do suggest to my patients to also go and check up for information on Google. They will find a lot. Sometimes they get misled also because there is it is an uncontrolled source of information, and a lot of wrong things and the right things are written on the net. So it is a double-edged sword. But a very good point by Dr. Bali, and I read your article. It was a beautifully written article in the newspaper.
Yeah, thank you so much for answering this question very nicely and convincing me that yes, maybe telling people to go online may make my job a little easier and convince them more. Now, coming back to Dr. Suri's question about the screening, I must say that what Dr. Bali said about cardiac MRI, actually cardiac MRI and cardiac PET have become very important in screening patients who can be prone for sudden cardiac arrest because of arrhythmias. Over the time, we have learned a lot of things, and in addition to only echo, which we do to see how the structure of our heart is, how the functionality of our heart is, over and above the information that an echo gives, cardiac MRI and PET CT, the cardiac CT, it gives us more information to guide the patients in the right direction as for the further treatment, whether they require it or not, and in case they require it, how aggressively we have to pursue that patient to prevent sudden cardiac death in that patient. So both these modalities have become very important in managing patients for prevention of sudden cardiac arrest. Anything
Dr.
else?
Venita, do you look for anomalous coronaries when you talk about coronary CT or anything beyond that?
So PET CT, I was saying. Coronary CT, yes, I do in an age group where I'm suspecting coronary artery disease malfunction, the congenital malformations of coronary artery disease. But PET has become really important modality, especially in the scar area mapping, especially telling us, over and above cardiac MRI, it gives us the area of the scar in the heart. I have got a lot of patients coming in, sir, youngsters coming in, who are into gymming, and they have either had palpitations and collapsed, or have had a collapse incidents. Some have lost their life. I have heard stories about it, but the people who have presented to me with gymming, I see a very good correlation of having arrhythmias and symptoms. And to my surprise, I found areas of scar in their heart, which were picked up either by cardiac MRI or just told to get a PET CT done. And this came after I had done their ablation, mapping their hearts. I had done their ablation, made them free. This came later, that they were given certain substances in the gym during their exercises, either not to feel tired, or they were made to sniff or take some tablets or injections. And even the proteins, some were on the proteins, substitute proteins. So I have a correlation with that. This is a very interesting correlation which has come to my observation. That's why I have started insisting, one, I go deeper into the history of gymming, of taking all these things. And secondly, I do get a cardiac MRI or a PET, cardiac PET, in case my radiologist wants to see something further. Over to you, Dr. Suri.
Yeah, so the cardiac MRI and the PET scanning, what you are using is for the muscle part of it. What Dr. Bali sir is saying, that we should also look into the CT angio for the not only for the anomalous origin of the coronaries, but for the anomalous course. Because sometimes the big coronary vessel or the main coronary vessel, it goes between the two main, the aorta and the pulmonary artery. And these are the vulnerable group of patients who are prone to have a certain cardiac arrest in young age, not because of the coronary blockage, but because of the dynamic blockage of the coronaries. So CT angio in such group of patients is one such indication where we should be utilizing it as far as the certain cardiac arrest in young people is concerned. So again, I am coming back to Dr. Vanitha. As we say, the prevention is better than cure. So I feel the mortality of certain cardiac arrest once the person has suffered from it is very, very high, and it's to the tune of more than 90%, even in US, and more than 95% in our scenario. So what are the preventive measures one should take to have from this certain cardiac arrest? And if a person suffers from the certain cardiac arrest and the bystander is there out of hospital arrest, how the adjoining people or the bystanders should behave, and how should they respond to it?
So there are two aspects of your question.
Yeah,
two different aspects. One is the prevention. How can a person prevent sudden cardiac arrest? Well, for the prevention, I would say it is very important for the people who have had coronary artery disease, an event with coronary artery disease, to get themselves evaluated, to have a regular checkup, and keep an eye on your number of ejection fraction on the echo. In case your ejection fraction is less than 35%, you fall in a group where sudden cardiac arrest incidence can be high. You have to be in touch with your cardiologist regularly to get a Holter done further, to analyze how high is the burden of any kind of arrhythmia in you, and then have the necessary measures done. Normally what we have seen and what the text says is that after a heart attack, there is a scar in the heart. In case there is a scar which is so large that your heart function falls to below 35%, then this scar gets activated 4 to 5 years after the heart attack. It becomes suddenly alive, I would say, and start causing arrhythmias. So, but that doesn't mean that those 4 to 5 years are totally safe. There has to be a close follow-up with the cardiologist and keep an eye on the ejection fraction. There are preventions which include that a medical therapy has to be taken regularly. There are certain drugs available now, newer drugs in the market, which improve ejection fraction. In case your cutoff line goes beyond 35%, you are in the safer zone. So those drugs should be given, and you should take them, have a good compliance, take them regularly, and be in touch with your cardiologist. Now, in case your ejection fraction remains less than 35%, then it is the decision which has to be taken to put a preventive device. We cannot prevent arrhythmias, but we can prevent sudden cardiac death. So that device is known as an AICD. I'm sure Dr. Suri is going to discuss that in detail a little ahead of in the session. And this is an automatic implantable cardioverter defibrillator, which is like an emergency kit which is implanted in the body of a patient, like a pacemaker, a little bigger than the pacemaker. Functionality wise, it gives us more function because it keeps on observing each and every beat in the heart. As soon as it sees the heartbeat goes fast or out of range, then it delivers a shock to interrupt in that rhythm and restart the heart with a normal rhythm, hence aborting the sudden cardiac arrest. Now, the second part of the question was what to do in case you find, if you are a bystander to sudden cardiac arrest. Well, if somebody nearby or where you are going around suddenly collapses, suddenly falls down and has lost his consciousness, the first 6 minutes, as Dr. Bali said, are the most important in that to save that person's life. The first 6 minutes, if anybody standing near that person who has collapsed, they start to think rationally and they start to act, then the life can be saved. And that is in form of a cardiopulmonary resuscitation. The CPR needs to be started immediately. The first 6 minutes is the most important time. With every passing minute, the percentage of surviving that person surviving from that sudden cardiac arrest goes down by 10%. So each and every minute that you are wasting, you are decreasing the chances of that person to survive by 10%. It is mandatory that everybody should learn CPR. Everybody above the age of 14 should learn cardiopulmonary resuscitation and know how to do a CPR and save a life. How far you want to discuss this, Dr. Pavan?
Yeah, I feel, this is the platform for the, the general public. If you have any video or you can show how the CPR should be conducted by the bystander, not by the professional, but by the bystander, whosoever is around. So it will be a good idea to share that video, that how to go ahead.
Sure, I can. Can you see my slides?
Yeah, we can see.
So you can see the slide of CPR being done. Unfortunately, I don't have a video to show a CPR, but I do have this slide whereby you can see there is a man on the road. He has collapsed. He's lying down, and there are 3 people in the vicinity. One, you can see the mobile in the hand of one of the person. So if you see this happening, that somebody has dropped, then the first and foremost thing is that you have to call for an emergency number. You have to call for an ambulance or a medical help. You have to make, the other person has to make the person lie down straight on the back. You can see this, the person has been made to lie down with the belly up and back down. You have to call out for that person to know whether he has really lost the consciousness or not. And you have to scream really loud, tapping there, and ask if you're feeling okay. The next step is, in case that there is no response, the next step is to look for the pulse and for respiration. To see the pulse, what you have to do is use your 2 fingers and put it on the nape of your neck here. And here, this is the angle of the jaw where you can find the carotid pulse and feel for the pulsations. So just keep 2 fingers here and see if you can feel for any pulsations for carotid pulse. And then respiration has to be looked from the side, move towards the side of the person and see if the chest is moving and it is going up and down or not. In case you do not find any signs, neither he responds, nor there is a pulse, nor there is a respiration, then you have to start CPR. And this is how the CPR is being done. This guy whom you can see in the picture has made the right posture to start the CPR. Look at the angle. First, you have to bear the chest of the person. Feel for the center bone, which is known as sternum. Go to the lower end of the sternum. Wherever that bone ends, there you have to put your palm. You put palm of your hand, lock it with the other hand like this, and with this part of your hand, you have to give the compression. As you can see in this picture, this is how the hands have been locked and the compression is being done. The angle with your the angle of the arms with your shoulder has to be straight. You have to be on your knees, and the back, look at this back. You don't have to slouch. If in case you slouch, you will not be able to put pressure on the chest. So the back has to be straight, and then there has to be this straight angle between the shoulder and the arms, and you have to push the chest so that the heart of that person pumps the blood to the brain. So there has to be a 2 inches movement of the chest when you are compressing it. You have to compress the chest at least 100 times in a minute, and it is recommended that you continue this compression for 10 minutes or till the help arrives, or there is any other person comes to help you out. Because generally in 10 minutes you would fatigue yourself and you will not be able to give effective cardiopulmonary resuscitation. So this is how CPR is done. Please, in case you want to further elaborate it, Dr. Suri, Dr. Bali sir, Dr. Mathur.
Dr. Vanitha, stop sharing.
Okay.
This is very well explained by you, Vanitha. So it's very important that as many people in the country can learn to do a CPR. You never know when you will save a life of either a near or dear one, or maybe somebody not known to you. But each life is valuable, and these basics, ABC of CPR is very important for everyone to learn. And that's about it. You've done it very well. There is also an incidence of increasing incidence of use of AEDs all over the world in international airport travel, terminals, malls, and everywhere else. I think, Vanitha, you might have a video on that also.
Sir, I will play that video. You can explain. I will play that video.
You should explain. It's your video. Yeah.
No, sir. It's okay. Please go ahead, sir. Yeah. I'm sorry, sir. I'll just put down the volume. Yeah.
Dr. Mathur, please unmute.
So for common men, it is important to understand AED is a external defibrillator, which is a very simple to use machine. And this is a small bag which is maybe available everywhere. If you look at even airports in our country, railway stations, and it is supposed to be available more and more places in big offices and malls and everywhere. And you can really save a life. All the instructions are very clearly given on the AED. You have to do these steps 1, 2, and 3. So once the patient has fallen and you have got an AED, you confirm that his heartbeat is not there, he's not breathing, he's unconscious. So then this is the patch which you take out from the AED and apply it on the chest, as they will show you. So peel off the cover and put this on the chest. So one of the patches is in the front and other is on there. And then you go to step 2, and this machine will automatically monitor the heartbeat and also give the shock to the heart. And this shock is basically to jump start your heart. Now, what we see in hospitals, you have doctors taking 2 paddles and putting them on either side of the heart, and then giving this electrical shock to jumpstart the electrical activity of your heart. So you can repeat this. If the first one doesn't work, you can repeat it. And in between, you can continue to do the CPR, cardiac massage, which Dr. Vanitha has so well explained to you.
Thank you.
Over to you.
Thank you, Dr. Mathur, sir, and Dr. Vanitha for showing this the life support what we can do for the patient. So, Dr. Bali, sir, as Dr. Mathur has already said that every individual should learn about the CPR, and he has talked about the hotels and the malls and the airports where the AEDs are also there intact. what is your suggestion, and how should we get more people involved in this process, in the process of getting the learning the CPR and in the process of using the AED machines? What should be the target population, and what should be the target?
I think that's very beautifully explained that everybody should know CPR, and Fortis Hospital and Mathur knows it very well. In Chandigarh also, we had taken an initiative to train people from different walks of life about CPR, and I think this should start right from school children, and right from the 8th, 9th class. These children should be primed that CPR is a technique which they should know, which they can utilize at home and otherwise. We had trained police personnel, we had trained other individuals, technicians obviously know, and these we have trained basic cardiac resuscitation people available and who can guide people. So in a group of people, we should train as many as possible. And that is, we should go to a stage that the person standing next would be trained in basic. That is, the original started from Texas, where they had a Texas heart watch. And they started teaching everybody about CPR, and that should be the objective in every person should have. And I think school education is the best to start doing it. It saves life. And in the video, very clearly it was mentioned how to do a CPR, because what is misleading is what we see in Indian movies. And in Indian movies, they take literally the word cardiac massage in a massage, and you see that's a very bad view for the public, and they believe that that is the way to go about a CPR. CPR, I think that video, what Dr. Vanitha has put up, should be very widely available to everybody to see that should be the position of the person doing CPR and what actually looking for CPR and what is the way to perform that CPR. I am absolutely in agreement that not only they are already available in airports and other things, AIDs, but even the house resident welfare societies in every place should have an AID available. I have gone on to the extent of writing an article on this to say that people who have elderly people at home, AID, this cheap device, and if you look at one life saved, it will be that will be a very gratifying thing. So AID, everybody should be aware of and should know how to use it, because you might find in a market or somewhere, and they should be widely available. The objective should be, as we have uniform education, uniform literacy, we should have uniform adult CPR training objective, and we should have AID available as widely as possible. That is the only way we can increase this 2 to 5% survival rate and make it 30% so. What we need to remember is that if a person survives SCT, he may have a near normal life. So we are not looking at a short-term gain. We are saving a young life for a long-term productive life, both for the family, for professionally, and for the society. So we should make all efforts to save lives for SCT with CPR, AIDs, and awareness.
May I add one more, sir, point here?
Yeah.
So, Dr. Suri, the AED, which Dr. Wali just said, my motto is that wherever there are fire extinguishers, wherever we have kept fire extinguishers, there should be an AED also with that. So if we construct a building, and as per the building laws, we have to have a fire extinguisher there. We should have an AED also there. I think we should propagate this, at least to start with. We should have AEDs placed there where the fire extinguishers are there, on every floor, on every metro station, in every mall. They should have, in all the trains, they should be there. There was a spree that was there in Delhi, which started, and we had a couple of metro stations which have AEDs now. If you go down, if you come from the airport, while you're coming out from the door, you will see a sign of AED there, which has been kept on the airports, also international as well as domestic. But apart from that, I don't see it so prevalent anywhere else. In case we keep the AED wherever there is a fire extinguisher, it will be a good start. What Dr. Bali said, that everybody should be having the coverage to have an AED. I think it should be a good start. Even for schools, sir. I say every school should have an AED. Wherever there is a playground, wherever there is a football or hockey or cricket ground, there should be an AED there. It saves life.
And the cost of AED is very less. It's
Yes,
less
sir.
than a lakh. So it is easily affordable in these places.
Absolutely.
I think we run a heart foundation. Decided that as part of our community awareness program, we would be donating about 5 AIDs to be put into the various markets in Chandigarh. We were in talks with the Chandigarh administration, but nobody could ensure security of those AIDs. So that is an issue. I think if we can have a system by which, supposing an ATM man can be given responsibility to take care of AID, many people would be ready to donate AIDs to be put in different places, and that would be a very good idea to go for.
Yeah, that's. I really agree with all the three panelists that we should start the program of CPR in the schools only, and all the institutes and the societies also. We should try to train and use these AEDs.
In fact, if I can add,
sir. I was coming.
There are lots of CPR videos available on YouTube. Anybody who's actually watching this program, because while we were discussing, I went to YouTube and I saw there's some very nice videos which explain how the CPR should be done. So I would request and suggest everyone, please just spend 2, 3, 4 minutes more after this discussion is over. Go to YouTube and right now, today itself, see how a CPR is done.
And sir, one more thing I want to add here, with your permission, Dr. Suri, that any kind of CPR is better than no CPR. If you don't know how to do a CPR, it is fine. Whatever you know, try it. Because whatever you will do, you are not harming. The patient is already dead in case you are not intervening. You saying something, Dr. Suri? I know something is going on in your mind.
Except the CPR, what Akshay Kumar showed in one of his movies.
Dr. Suri, there is a concept coming that even drones can be used.
Yes, sir. In French, it has been used.
Remote areas, and you can on phone guide people there to say patient with SCD. And there was a YouTube, Dr. Mathur mentioned, there's a YouTube where a child, 11-year-old child, was advised by the ambulance people how to carry on a CPR.
That was a drone carrying AED.
Yeah,
Correct.
absolutely.
Correct.
So we are moving towards that, but we need to have more awareness on this particular area.
We have in the healthcare setup also, we have the CPR machines also. We are wrapping that around the chest and it's automatically giving the CPR so that the perfect CPR and the right CPR is given.
Auto pulse.
Right compressions are given. Auto pulse, Right compressions are given. So definitely, as Dr. Bali has already said, that they had started an initiative, but seeing the Indian scenario, that people think that everybody is a thief and that AED may be lost somewhere. So that idea was dropped. Because I'm not annoying anybody, but wherever the politicians come, this thought process again comes there that this is going to be lost in 6 months or so. So, Dr. Mathur sir, one question I want to ask you, since we are talking about the CPR in the COVID times, what we are facing right now. How challenging is to do the CPR? Because in CPR we have to be very close to the patient. We have to get almost 5-6 people around, so that when we're doing an advanced life support, not the basic life support, when we're using the medications, ordering one thing, second thing, one is doing the resuscitation on the cardiac side, other is doing the resuscitation on the respiratory side. So how difficult and challenging is it for the healthcare workers to do the advanced life support, and what precautions they should take? Because maybe our friends may be watching this, or this message should go to them also, our anesthetist friends and intensivists.
See, this COVID pandemic is a big scare, and everybody is scared to do anything. Everybody is paralyzed, and similarly, performance of a CPR has been hugely affected by COVID, because if you have a COVID patient or a suspected COVID patient, and if you have to actually perform CPR and then advanced life support to get an airway intubation and other things, then this is where the infection lies, in the nasopharynx of the patient. So, and the person who's performing it, and if he's not well protected, then he is at a very high risk of getting this illness. So, in hospital settings, for advanced cardiac life support, every hospital has a protocol where you have to, within quick time, you have to don a PPE kit to protect yourself before you go in to do a CPR. But if you do not have access to PPE kits, and it is very difficult to let somebody go away like this, I think you can use your basic precautions of wearing a good mask, maybe if you are already carrying a face shield, or you can try and cover up the face of the patient who is drop dead, and then continue with the CPR. And if you are successful, you have saved their life, and then go and protect yourself by sanitizing yourself, taking a wash yourself, and do other precautions. But of course, you have to make sure that you're protecting your face and your nose and your eyes in a good manner, so that any secretions which come out to you are not the infected secretions which may jump into your face are not getting you the infection. Otherwise, I don't think there is a gold standard how one could go about it. But you should not be scared in saving another life, and try and protect yourself at the same time.
Thank you,
Dr. Bali, Dr. Vanita.
Yeah, before I get I think we have crossed the time, and I'm getting the messages on my phone also. So before I get the final message from all the three experts, I have two short questions. One for Dr. Vanita. The question is, how long does it take to die from the cardiac arrest?
The first 6 minutes are the most important, Dr. Suri. In case you start the CPR within the first 6 minutes, you can save the life. Otherwise, with every passing minute, the incidence of survival rate goes down by 10%.
Okay.
So 6 minutes. 6 minutes.
First 6 minutes.
Yes.
6 minutes जिंदगी के.
6 मिनट जिंदगी में 70 मिनट नहीं है हमारे पास 6 मिनट.
So there's another question for and it is a special mention about Dr. Bali sir only. The question specifically for Dr. Bali. So sir, I'm not biased towards you. It's a specific question to you. What is the difference between?
I would like to know the name of that gentleman who wants specifically my.
So how do you know it is a gentleman? How do you know it is a gentleman?
Yes,
so
please.
Whosoever the gentleman or a pretty lady, the question is to Dr. Bali sir, what is the difference between AEDs and defibrillators, commonly used in ambulances, hospitals and TV shows, especially of Arnav?
Arnav?
Republic TV, that is showing the AEDs. The difference between the AEDs and the defibrillators used in ambulance, hospitals and on TV.
No, I understand why the question is directed to me. I will not bite the bullet and leave Dr. Vanita to answer that question.
No, sir. So you start, I will continue. Please. I would not know how to handle the political part of it, sir. So you please start. I will continue.
There is a specific mention that specific to Dr. Bali sir. So maybe he or she might be the regular reader of your write-ups. So she or he knows the inclination. So Dr. Bali sir, you have to answer this question, and then we will have to get the wrap-up message from all the three.
I think the basic all the defibrillators we have is same, that whether they are in ambulance or in the hospital, or they are a little larger machine, they have a little more functions and synchronization in a portable thing which we have an AID. Basic job is done by giving defibrillation. So the mechanism of action is same, and there is no problem. It's a portable thing, and it can be used, a battery operated thing, so it can be used everywhere. So what we use in the lab or elsewhere in CC or in other places are more sophisticated. They have more charging is much faster, and we have a synchronization of defibrillation, and we can have various things done. In an AID, there is only one shock which we can give. We can't vary the joules which we are delivering. So that, as far as Arnav is concerned, I can say that there is another person, Jacob Zaka, who's a very strongly giving him competition as far as carrying out defibrillation is concerned. Arnab is doing a defibrillation for the entire country, and that is what he is like. He wants to reset the country by getting the normal system of thinking back, and I will leave it at that. More power to him, and that is what I would say. Keep watching him to learn more about defibrillation of a society rather than defibrillation of a person who has got a sudden cardiac death. Dr. Vanita, please.
Sir, I will just endorse the first two comments which you made. First on the defibrillator part, which is in the hospital. You are absolutely right. It is a very interesting and a sophisticated device which helps us treat arrhythmias. It has external pacing modality also, in addition to defibrillation, and we can adjust the modulation we want to plan for the patient and how much voltage we want to give to defibrillate the heart. AEDs are there to help us. They are not replacements to defibrillators, but they are a good guidance to a bystander or to the paramedical person to help restart the heart, and they analyze the rhythm well, and they give the instructions to save a life. So I don't think so one can be replaced by other, but both of them are as important in the clinical practice. Defibrillators cannot be everywhere. They can be in the hospital and clinics. So AEDs can be everywhere. So henceforth, they are very important. And the third part of the question which you answered, sir, that is up to you to defibrillate the country or whatever.
No, as
you are a better judge on that. I am nobody.
Yeah, as I am associated with Dr. Bali for since I feel 2009 or 10, so I can take the liberty of using the defibrillator. The difference between the usage of defibrillator in the hospitals and on the TV. In the hospital, the defibrillators what we use is based upon the joules or the joules we give, the shock we give, and in TV it depends upon the pitch, about the pitch of the voice, which gives the defibrillation to the audience. So we have different series. We have Republic, we have Hindi Republic, we have others giving the different pitches and different defibrillations. So that is a different scenario, and that I feel that Dr. Bali sir has rightly discussed about that part. So one last question to Dr. Mathur sir, because he is smiling. So one question is, once a person has suffered a certain cardiac arrest, what is needed to prevent another one?
Anybody who smiles will get a question.
Exactly, sir. Exactly.
So once a person gets a cardiac arrest, and he has been lucky that there is help at hand, and he's been given proper CPR, defibrillation, and he's been revived. And there are lots of people who can be done that way. If he gets timely help with the good CPR and defibrillation, then the lives can be saved. After that, you have to get a thorough evaluation of why the sudden death happened. Why did the cardiac arrest happen? Which will include to see whether this person has had an acute heart attack, or if it is not an acute heart attack which is ongoing, then you have to immediately start treating for his acute heart attack. Otherwise, if it is not an acute heart attack, then you got to look at his ECGs and his echocardiographies and see whether he's got an enlarged heart, which was the cause for his defibrillation. Was there any electrolyte disturbance? Salts imbalance can also lead to electrical activity going haywire. And also is whether the heart muscle is thick and all other causes which we have discussed. So once you get after saving the life, you get to diagnose as to why this happened. A detailed cardiac and neurological and other evaluations for this patient have to be done so that we can prevent this in future. If it is a weak heart, then you're looking at these special pacemakers which Dr. Vanita Ports and Dr. Bali Port, which are the CRTs and CRTDs, which are like another type of defibrillator, which is in the matchbox size put under the skin. It is a special kind of a pacemaker, which will detect again automatically when a person has an irregular heartbeat and heart arrest happens. It will within seconds, it will give a shock through the wire, which is of lower intensity because you're directly giving it to the heart. And it jumpstarts the heart and saves the life once again. So this is a third kind of a defibrillator which we are talking about, which is implanted in your body in the form of a pacemaker. So some people may require benefit by that. So this is a detailed evaluation to be done for patients and then guide them to life-saving measures, including a AICD, implantable cardioverter defibrillator. Over to you.
Dr. Suri, can I take a minute?
Yes, sir.
We recently had a patient.
Yes,
He was the brother of our very senior professor in PGI, and we done an angioplasty on him in 2001. And Tier 1 MI, and we did an angioplasty at that time. Subsequently, he had another angioplasty in 2014, where the right coronary was opened up. And this time, his son is a additional professor in PGI in medicine department, and he came about 2 weeks back, and he said that he has some sudden loss of memory, or he forgets, and there is something to suggest that there may be a pre-syncope. So we evaluated him, and his ejection fraction was 30%. And I said that anyway, we should be looking at an ICD in this particular patient, but let's get a Holter done. And we got an Holter, which did not show any arrhythmia, and we got an ELR done. And ELR showed that there was non-sustained ventricular tachycardia lasting for about 3-4 of them for a significant length of time. And there were no symptom correlation though. And we said that he needs an ICD. He has a previous MI. His ejection fraction is 30%. And now he has this history of doubtful pre-syncope and ELR showing non-sustained ventricular tachycardia. He should have an ICD. So we advised him an ICD, and his other son is in US, a doctor. He talked to me and he said we should put an ICD. So he said we'll get a COVID test done and come after a COVID test done. He goes home, gets a COVID test done, and he on a Wednesday, next day we were supposed to admit him. And in the night, his son rings me up that he had a sudden cardiac death, and because the son was besides him, he gave a CPR and revived him. And he was admitted in the night, and next day we put an ICD. So this is what has happened last week. We discharged him 3 days back. So that is what actually proves what is the natural history of patients with cardiac with an MI. An MI followed by LV dysfunction, and we were lucky that his son was with him, and he was able to save him with the CPR. So that all this was very recent. So I thought I would narrate that story, and we were lucky to have him up and about and recovering from an ICD procedure.
Thank you, Dr. Bali. It's an example worth this discussion, and it wraps it all that we need to have a CPR person, a bystander who should be able to do the CPR, and one precious life can be saved. This is a perfect example of what we wanted to discuss. We have discussed over last 2 hours or so. And as Dr. Mathur previously said that those people who are smiling only will get the questions, and after that I don't see a smile on any of the faces. But still now I have changed my strategy, and I will ask the last question to all those who are not smiling. So the one last question to everybody, and everybody have to answer it. Forget about being political, forget about being apolitical, because we have to understand our role in the society. Because whatever we gain from the society, it is our duty to give it back to the society. We have become the professionals because of our hard work. We have become the professionals because we have seen the surroundings, we have grown up in the surroundings, and we should be very bold enough to raise our voices, to put our stuff forward, and if something is happening wrong around, we should be able to raise our voices as well. So apart from being the professional, we are social beings, and we should be bold enough to hold that on our back. So one last question to all of the my experts, my masters, my mentors, and you have to answer it separately, so no one can escape this or pass the buck to other expert panelists.
Smiles or no smiles?
The question is, I will start with Dr. Bali sir, because he always sets the bar high. So the question is, can the heated or the hatred discussions lead to heart attack? The heated or the hatred discussions on the channels lead to heart attack. As recently, we are witnessing a very hatred and aggressive debates, I forgot to, this thing came into my mind. One of the spokesperson from Congress, I'm not biased towards one political party, but that person, while on the debate, had a heated discussion and he had a sudden cardiac arrest within half an hour after the discussion. He was the spokesperson from the Congress. So that made me to ask this question: can the heated or the hatred discussions lead to heart attack? As recently we are witnessing a very aggressive and hatred debates, discussions, more of voices, less of the material, more of an intent, less of the content we are witnessing on the channels.
I think I will agree with you that we need to cool tempers all around from all political angles, and we need to have a more civilized debate. And I will give you two episodes. One, you mentioned that there was a spokesperson, Mr. Tyagi, who had a sudden cardiac death after a heated discussion on a TV. I remember another person who was a purchase officer of PGI, and he was sitting in a meeting with the director, and director asked him a few questions, and he got very angry, and he got chest pain, and he had a prolonged pain with ECG. And from the director's office, we shifted him to the cath lab, and he had a critical lesion in LAD. In fact, we did an angioplasty on him on the same day. So I know from personal experience that very heated arguments can make a stable block may be unstable, and we should have because of a variety of reasons. So I think we should that is why our relaxation exercises come into focus, meditation comes into focus, and yoga comes into focus. So I would suggest that not only our country, the entire world at this moment needs calming personalities. We need Vivekananda, we need Nelson Mandela, we need more such cool passions all around. And you go on the roadside, you have your vehicle stopping for 1 minute, and you have everybody honking on your back and people abusing you and whatnot. And that's becoming a worldwide phenomenon. We're becoming a very less tolerant personality all over the world. Human beings need to be more tolerant to each other, cohabitate well, and that is absolutely essential. That will make us a better society, and that will prevent lifestyle diseases as well. And in the initial stages of COVID, it was said that the heart attack is decreasing because we are getting less people going to the office and the stress level is come. Although that theory has no more believed that, but I would be strongly with you when you say that we should take every opportunity to cool passions around and become more tolerant. And that is not in India, that is a worldwide phenomenon. That is what I would say. It can certainly precipitate events.
Dr. Mathur, sir.
As far as I'm concerned, I have lost faith in these TV channels. They all have agendas, and they thrive on provoking people to fight with each other. So without even referring to them, I've stopped watching them. So otherwise, anybody who is agitated will have a surge of hormones in his body. And if there is any iota of underlying heart disease, like a plaque, atherosclerotic plaque, which can rupture, or there is already existing disease, severe disease, you can cause a plaque rupture in an acute event. Or there is a surge of these hormones can lead to electrical instability on its own if the heart is diseased. So there is definitely a high risk when you are provoked and you are agitated. So you can definitely get a heart attack. You've seen this in Hindi movies also being very dramatized, but it's not always like that. So that's my take on this.
Dr. Vanita.
Yeah, Dr. Suri, I'm the most apolitical person. I have no idea about politics. But just to answer your question, what I would say is, in consensus with Dr. Bali and Dr. Mathur, that stress of any form, takes the toll on your heart. Any form of stress to anybody. And adding to this an emotional aspect, that with the last about 7-8 months of Corona has made us realize how fragile the life is. We have all experienced such episodes during our clinical practice, in our day-to-day practice, that there have been very emotional incidences in so many families, and Corona has actually reset, at least it has reset my mind totally, to believe that life is very fragile, and any kind of stress or negative thoughts or any TV channel or any outbursts. At least I don't want them around me. Corona is enough in itself. It has made me realize how important life is and how precious life is and how important people are around me. You know, I have learned to give importance to them rather than to give importance to any kind of a TV channel outburst or anything. So that is my take on it. I think it was a learning lesson for all of us, resetting our lives, and we should reset our life and, you know, live better. That's all I can say.
Thank you, Dr. Bali sir, Dr. Mathur sir, and Dr. Vanita. So I feel we have crossed the time. I am getting the messages again and again. So should we conclude it or?
You didn't answer this question yourself, Dr. Suri. I want to put the same question to you. You should answer and then we conclude. What do you say, Dr. Bali, Dr. Mathur sir?
Yeah. I'm ready to answer. I'm ready to answer the questions.
Uske paas hai answer. He knows the answer.
I know the answer because, you know.
He has been asking the questions from all of us, you know, in the entire session.
He's giving a challenge to so many people who want the country to know.
Correct.
He wants to know.
Correct.
So he has all the questions.
You know, I want to tell, you know, I have been taught by the mentors who are right on the screen right now, and I feel what Dr. Mathur has said already, that I have stopped watching the TV channels. Believe me, I have not watched since 22nd of March. And there is a constant, you know, I don't call it a fight, but constant, you know, discussion between me and my dad. My dad watches the TV. He is a very good fan of Arnab. You know, he watches his noise, and then I do come from the hospital, and then he starts his story. Pawan aaj iske aise kar diya. So personally speaking, I have stopped watching the TV channels, not because of any bias towards anybody, but you know, your mentality or your thought process gets changed just because of their personal agendas, as Dr. Mathur has already talked about. And there is more of an intent behind the channels. Not the content is day by day decreasing. And I had written in an article, an editorial also on this a few weeks back about the noise created by the media channels and how the media had changed from the earlier ages to present times. So I feel we should more focus upon our own work, and we should more focus upon the responsibility what we are. We should behave more as a responsible citizen rather than as the forward agents. Like most of the people are the forward agents on the WhatsApp groups or the Facebook groups. Without reading the messages, without seeing the videos, the people are forwarding the message and just circulating for no reason. So we should stop forwarding the messages like this and that. And focus on our own work and focus on our family and friends, be with the friends and enjoy the way it goes. That's what I can say. And after that, I thank Dr. Bali sir, thank you very much, Dr. Mathur sir, thank you very much, and Dr. Vanita, thank you for your being here. It's your birthday and enjoy the day. And at the last, I want to thank the HealthWire media people who actually organize all the technical team behind our getting together here virtually, and they have managed it very nicely, and I thank them from the core of my heart. And lastly but not the least, I thank the people who have watched it, and I will be happy enough, and in fact all of us will be happy enough if we have been able to give something to them. And as Dr. Mathur sir, again, he is a great teacher, and he has advised the viewers not to take their lunch, though he's getting the calls from the kitchen that come, Dr. Mathur, the lunch is ready. So he has given them the homework. He has given them the homework to look for the CPR videos, and I feel it will take 2 minutes or 4 minutes for them to watch those videos. And this is the way how he used to get his work done. He used to teach us this way only. Food or no food, but get our work done. That's how typical our teacher, Dr. Mathur sir, is. And thank you, Dr. Bali, for being here. And I feel you are the most laid person, most calm of all the people, and we feel and want more of Dr. Bali's in our profession, more of Dr. Mathur's in our profession, not as a profession only, but as a human being, and more of Dr. Vanita's as well in the electrophysiology. And the one good thing what this platform has done is that Dr. Vanitha has finally agreed that interventionists are also the nice people. Thank you very much. And
I never made a comment that interventionists are not nice people. They are the best people. They are my best friends.
thank you.
Only they don't admit.
No, we admit. We all admit. We all admit.
Thank you very much, Pawan. It was a great, great chatting with all of you.
Same here, sir. Thank you very much for being here. And Dr. Vanitha, thank you very much.
Bye-bye.
Thanks.
Thank you. Bye, Dr. Mathur. Bye, Dr. Wali.
Bye, all of
Dr. Pawan.
you.
Happy birthday.
Have a nice day.
Thank you so much, sir. Thank you so much. And
Blessing.
applause to you all.
Blessing.